Welcome, PG students and surgical fellows. Today, we're diving into a true foundational text of pelvic surgery. We're looking at Dr. Milton McCall's seminal 1957 paper on the posterior culdoplasty. Let's be real. If you're going to be reconstructing the pelvic floor, you absolutely have to know this technique inside and out. We'll treat this explainer like a surgical masterclass. We'll start with the anatomy of an enterocele, look at the evolution of the repair, break down the internal suture technique, see how to build the vaginal vault, and wrap up with clinical results and outcomes. Section 1. Anatomy of an enterocele. Let's look at exactly what you'll be facing in the OR. So, what exactly is an enterocele? Essentially, it's a posterior vaginal hernia of the cul-de-sac of Douglas. Now, whether it's congenital or, as you'll see a lot, acquired from delivery trauma, recognizing this defect immediately is absolutely crucial. This is especially true during a vaginal hysterectomy. You literally cannot afford to overlook this outpouching. Take a look at this image. See that prominent bulging sac right behind the cervix? Back in McCall's day, authorities agreed on one major thing. Missing this high posterior laxity during surgery is, hands down, the most common cause of late postoperative complications. Basically, it sets the stage for a complete prolapse of the vaginal vault later on. Section 2. Evolution of the repair. So why did McCall feel the burning need to invent a brand new approach for this in the 1950s? Well, for some quick historical context, surgeons had recognized this specific hernia since 1736. Then, in 1922, Ward popularized repairing it via the vaginal approach. But for centuries, fixing this hernia came with a really steep anatomical cost to the patient. You were essentially trading one problem for another. This quote right here really highlights McCall's main frustration. Older techniques cured the hernia, sure, but they essentially sacrificed the patient's normal anatomy to do it. They notoriously shortened the vagina and narrowed its upper portion. McCall realized, hey, curing a hernia shouldn't mean we have to compromise the depth and function of the vaginal canal. Section 3. The internal suture technique. To fix this anatomical dilemma, McCall came up with a highly specific two-part method, and it begins internally. Let's break down the mechanics. After the vaginal hysterectomy is completed, here are your steps. First, get the patient in Trendelenburg to expose the lower peritoneal cavity. Next, evert the sac. Then, grab some non-absorbable suture. McCall used silk, cotton, or linen, and pass it through the left uterosacral ligament, about 2 centimeters above its cut edge. Then, you're literally going to walk across the redundant sac, taking bites every 1 to 2 centimeters, and finally pick up the right uterosacral ligament at that exact same level. Study these diagrams closely. On the left, you can see the E version of the enterocele sac, which shows you exactly where those sutures need to go. And on the right, you see the continuous internal suturing in action. By bringing those uterosacral ligaments together right in the midline and incorporating that redundant sac, you're actively obliterating the defect. Now, you aren't just going to throw one stitch and call it a day. While the size of the enterocele dictates the exact number, you'll place an average of 3 internal sutures. And here's the key. Each one goes successively higher than the last. You're basically rolling that relaxed cul-de-sac outward, stitch by stitch, until there is absolutely zero hernia left to become incarcerated. Section 4. Building the vaginal vault. All right, once that internal defect is transformed into a firm, shelf-like structure, we move to part 2, reconstructing the vaginal vault. For this phase, you're switching to absorbable chromic gut. Notice how these are inserted from the vaginal side. You go straight through the cul-de-sac tissues, pick up those left and right uterosacral ligaments again in the lower peritoneal cavity, and come right back out the vaginal wall. You'll usually place about 3 of these external through-and-through sutures, again moving successively higher. Pay very close attention here, because this is the absolute critical pearl of the whole procedure. McCall insisted this top point must be carefully delineated by palpation. Getting this highest external suture perfectly placed is exactly what guarantees the new vaginal vault sits at the highest possible level. And here's how it all comes together to build the final result. After you tie the internal sutures on the peritoneal side, you tie these external ones on the vaginal side. Snugging these down pulls the vaginal mucosa tightly against that firm, newly built peritoneal shelf. And notice what we didn't do. We completely avoided excising any vaginal mucosa. Section 5. Clinical results and outcomes. The anatomy makes total sense in theory, but as evidence-based practitioners, we need to know, does it actually work? Well, the contrast is stark. Unlike those traditional repairs we discussed earlier that routinely shorten and narrow the vaginal canal, McCall's posterior culdoplasty does the exact opposite. Because no tissue is removed, and because of how the ligaments are used, it actually lengthens the vagina and widens it at the apex. It's a total game changer. And the clinical data from McCall's preliminary report proves this beautifully. He actually measured the vaginal length from the vault to the posterior fourchette in patients with severe prolapse. Look at this table. These patients started with an average pre-op length of just 4.6 centimeters. And post-operatively, they hit a remarkable average of 8.9 centimeters. To put that in perspective, normal vaginal length is generally cited as 8.5 to 9 centimeters. So we're talking about a complete restitution to normal anatomical length for these patients. To really drive this home, check out this sagittal view. This is the preoperative state. Point X shows you the lowest extension of the hernial sac, just prolapsing dangerously downward and pulling the anatomy with it. Now look at the masterpiece result after the Culdoplasty. Look where point X is now. That previous lowest portion of the hernia has been drawn all the way up. It's suspended strongly and securely by the uterosacral ligaments right at the apex of the reconstructed vagina. The redundant cul-de-sac is obliterated, and the vault is incredibly deep. Which leaves us with this final thought. As future leaders in pelvic surgery, you aren't just fixing a structural defect. You're restoring a patient's normal anatomy and function. By understanding these precise anatomical anchor points that McCall mapped out back in 1957, how will mastering the posterior culdoplasty improve your own patient's long-term quality of life? I highly encourage you to review these specific steps and diagrams before your next pelvic reconstruction. It really will profoundly impact your surgical outcomes. Thanks for joining me for this explainer, and I'll catch you next time.